Goodness. So after the first couple of slices that we've done, I'm going to basically work my way through some PowerPoint slides and explain to you how ECGs work and kind of what they're trying to pick up. And I think a really good place to start is to have a little think to ourselves, well, why would we be actually looking at an ECG? Okay, so by and large, you're doing an ECG on somebody because you think there's something wrong with their heart. Okay, now when there's something wrong with their heart, there's usually going to have a problem in one of two things. One, there's going to be a problem with the plumbing, or two, there's going to be a problem with the electrics. Now, problems with the plumbing is stuff that we've been talking about in the previous 5 slices of the videos. With the electrics, this is where we need to start interpreting graphs. Now, the reason that I love ECGs as much as I do is because they're an opportunity to interpret 5 graphs at the same time. And that's all you're looking at on screen with this recording. Is just we've got voltage here, and on the y-axis and on the x-axis we've got time. So you can think about voltage or being an amplitude or something like that, and it's really that straightforward. You should really know everything that I've got on screen with me now. The P waves, they are atrial contraction. The QRS complex is the depolarization of the ventricles. You've then got this little bit here called the ST segment. The quiet phase of the ECG, that's where the actual ventricles are contracting. And then you've got ventricular repolarization on the T wave. Now, that's it. Okay, the only thing I really should be doing is just drawing the extra bit across like that. Poor Bachmann. Nobody ever talks about Bachmann's bundle, but there it is, and it's important. And you think about it, look, you've got the right atrium there, you've got the left atrium there, and it is only showing the bundles that are going to be carrying the wave of depolarization through the right atrium. The left atrium works as well. And actually, if you look at the shape of the Q wave, what that shows us is that the right and the left atria are contracting normally. And I'll do this with you on a next slice when we look at. I think actually I'm going to do this with you live in person. But basically, you can get a P wave that kind of looks like that. You can get a P wave that looks like that. You can get a P wave that looks like that. Okay? None of those are normal. A P wave should look like a neat little bump. Something to keep in mind for when we talk about stuff later. Alright. Now, where do I want to take you next? Let's have a little look here. So you should have done a session before you do a live session with me with Chris and or Trevor, where you've placed ECG electrodes either on yourself or one of your classmates. I just want to double check so that I can be confident that I've said it to you, what everything's doing. Okay, so we've got, as it says on screen, we've got these limb leads. Okay, and we've got the right arm, got the left arm, left leg, and the right leg. You can similarly take these up on the chest and dock them here, like that. Doesn't make any difference. And the reason that it doesn't make any difference is because these electrodes that we're putting on, or the leads that they generate, are what's called bipolar leads. And it means they've got a positive and a negative end. For a way of looking at it simply, if you want, is that these bipolar leads look across somebody's heart. Okay? They look across the heart like that. And they form a triangle. This triangle is called Einthoven's triangle. They look across the heart. Okay? Across the heart. These chest leads, okay, otherwise known as the precordial leads, because this part of your chest is called the precordium. So they are the precordial leads. These are unipolar electrodes. And it says we got a total of 12 leads from 10 electrodes. And that's because we're generating these leads like this. So lead 1 goes from right arm to left arm, 2 right arm down to left leg, and lead 3 in from left arm to left leg. And we would label these up as right, left, foot, and neutral, and therefore it's really straightforward for us to see why it is that nothing goes down to the right leg, because for all intents and purposes it's an electrical earth, a reference electrode for other things to work their way off. We get then these ones here called AVR, AVL, AVF, and we get them because the ECG will take this right electrode, the right arm electrode here, and it will say, okay, that's a negative end of lead 1 and this is the positive end of lead 1. And the reason that it's calling the left arm the positive is because the wave of depolarization is going to get picked up by the wave moving from right to left. So what we're saying is that these are just electrical vectors, and that if a vector is going towards an electrode, it's a positive. If it's going away, it's a negative. This is going to become really important when we start talking about cardiac access later. So what we get, if I just change my ink color, is we get a negative and a positive. We've got for lead 2 a negative and a positive, and for lead 3 a negative and a positive. Now I can feel you, even because we're doing this asynchronously and I'm not actually talking to you right now, I can feel you saying, what the hell are you talking about? Don't worry about it too much, it'll all become apparent later. Suffice to say that for now, what the ECG can do is it can take this negative and this positive, it can bring them together here, and it can look up at the heart that way. You don't have to know how that happens, okay? You just need to know that it does. So this is what's called an augmented vector, and it's looking towards the left arm. So AVL, augmented vector to the left. It's going to take this one, bring them together here and look at the heart that way, towards the right, AVR. Okay? And it's going to take this one, bring them together here and look down at the heart that way, towards the foot, AVF. Which is why we can get 12 leads out of 10 electrodes, because we're creating some mathematically. Again, it's not massively important that you know how that happens, but you do need to know that it happens and where they come from. And that's fine. Okay, just tidy up my slide here, and then we'll move on. Because we're actually going to start talking about the ECG per se. I've seen that you have a slide on this from Chris's preparatory work, and that's really good. What we've then got is an ECG split into two sections. So we've got limb leads, okay, or another way that we can now think about this is that we've got bipolar leads, and then over here we've got the precordial leads, or chest leads. These precordial leads are also something called unipolar. So they don't look across the heart, they look down into the heart. Now, this is important because they've got to be put in very specific places. Okay? And if they're not put in these specific landmark places, they're not going to be looking at the thing that you expect them to look at, and your ECG is going to be wrong. Okay, so if you put crap in to the ECG, you get crap out. It's just like anything else. I mean, you can have basic ingredients and a wonderful chef can elevate them a little bit, but ultimately, if the ingredient that you put into a dish tastes horrible, the final dish is going to taste horrible. In other words, if it's a crap ingredient, it doesn't matter how good you are, it's going to be crap. Okay, so we're putting these fourth intercostal space, right sternal edge, fourth intercostal space, left sternal edge. We then go on the mid-clavicular line onto the fifth intercostal space, then V3 goes between V2 and V4. V5 goes on the anterior axillary line, lateral to V4. V6 goes into the mid-axillary line, lateral to V5. The reason, again, that these have got to be so specifically placed is because they are unipolar leads. In other words, they look directly into the heart as opposed to looking across the heart. There's no negative and positive end to these. These just look down. That's it. They look into your body at the heart at a specific place. So in other words, if you put V6 where V5 should be, okay, so let me just get my laser pointer. If you put V6 here where V5 should be, you now no longer have any electrode that's looking at the posterior of the heart, which means if something's wrong with somebody's left ventricle, you're going to miss it. So it's super important that they put in the correct spot. Now, these basic limb leads, the form Einthoven's triangle that we just drew out, because they are bipolar leads and they've got a negative and a positive end, it means that we can change the way that we draw them. Okay, now this is very, very, very important when we're looking at something called cardiac axis, which I alluded to a little bit earlier. So essentially what we can do is we can just take Einthoven's diagram and we can redraw it, which is what's happened here. Okay, so you got lead 1, which looks from the right arm to the left arm, okay, with a negative and a positive end. So all they've done on this diagram over here is they've just brought the leads to the middle of the heart. They've just moved them almost like dragging and dropping. Okay, so you can see lead 2 there, and I can drag and drop lead 2 here, call that the center, and just put it down like that. Okay, with its negative and positive. So I'm just bringing all of the negatives together. Lead 3, therefore, comes in like this, and then they've actually taken the trouble to put on AVR, AVL, and AVF. This is called the hexaxial diagram, or the Cabrera diagram, named after the physician who first did it, Portuguese physician Cabrera. Okay, hexaxial diagram. It's going to be very, very important to be able to use this when we're looking for cardiac axis, but like I said, we'll come back to that later. Suffice to say that you can make this as complicated or as simple as you want, but I like to keep things as simple as possible. So all they've done is they've put the negative electrodes in the center of the heart and the positive electrodes pointing out. That's it. Okay, that is all they've done. And do not allow this diagram to be any more complicated than it needs to be. Okay? So that's kind of like a bit of background. What I would like to do now is to draw your attention to this slide, where we are taking the ECG complexes that we talked about earlier, and we're going to start to think about them like medics. Okay? So we know how long a cardiac cycle should be. We did it in Slice 2. Okay? We know what that all refers to and where the waves are coming from. So now what we're going to do is we're going to break down our cardiac cycle a little bit more, and we're going to say, right, okay, let's look at the ECG as a graph, and remember that we've got time on the x-axis. Okay? So each little box that you will see on an ECG, okay, is 0.04 of a second. Okay? So what I would prefer you to do is to not think about these ranges that we're talking about here in terms of milliseconds or 0.12 to 0.2 of a second, okay? I would rather you just think about them in terms of numbers of boxes. So if we're talking about small squares on an ECG, 120 to 200 milliseconds becomes 3 to 5 small squares, which means that now when you want to look at this P to R interval here to figure out whether atrial contraction and depolarization is taking the length of time that it should take, you know that this should be 3 to 5 small squares. That means 80 to 120 milliseconds is 2 to 3 small squares. So this should be 2 to 3. And then this gets a little bit complicated. The QT interval, so in other words, ventricular depolarization to repolarization, it says it should take no more than 440 milliseconds, in other words, 11 small squares, as long as the heart is beating at 60 beats a minute, because as we know that the faster your heart rate goes, it shortens the length of time that you get to spend in diastole. It doesn't do anything to systole. So in other words, this T wave is going to move left or right depending on how fast the heart rate is. So you've got two choices. You can either use this equation here called the Barrett's equation, or you can do what I do, which is I just click on that link there to MedCalc, punch in my numbers, and it will calculate it for me. The other thing that you can do, if you're going to eyeball an ECG, which is frequently what you have to do because you just need to know very, very quickly whether somebody's okay or not, you cheat. So here's a cheat. What you do is you find an R wave, okay? And I'm going to use this one here on the bottom, and another R wave, this one here on the bottom, and I'm going to take a halfway mark between the two. If my T wave comes on the left hand side, QT is normal. If it touches the middle, you get long QT. Why is that important, Lewis? Well, if you've got long QT syndrome, it is, for all intents and purposes, the greatest predictor of cardiovascular mortality in the young. Your heart spends too long in repolarization, and when it does that, things can go wrong. What I would like you to do before you come back to me and we do our session of reading an ECG together, what I would love you to do is to just go back over this, familiarize yourself with what a P wave is, what a QRS complex is, what the ST segment is, what a T wave is, and the normal ranges. Because the next time we come back together, you're going to sit, I'm going to stand, I'm going to write on a board of exactly how step by step to read an ECG. We're going to do it properly, and then the next time you come back, we're going to do some ECG problem solving together, and then hopefully then you'll be in a position where you'll be confident enough with a little bit of practice to read an ECG. See you next time.